Thank you, Dr. Alisa Savetamal, for talking to OnSurge today. I hoped you'd answer a few questions about the changes in management of fluid resuscitation in burns patients. Big picture, what has changed?
Thank you for having me, Dr. Porter. I think the biggest change in burn resuscitation now has been the adoption of what's called the 2010 ABA burn resuscitation formula. Other people also refer to it as the modified Brooks formula, and it's basically half of the Parkland formula, which we were all taught as 4 mLs per kilogram per total body surface area of the burn. So this is basically half of what we've all been taught to use in patients.
So if someone comes in, you still calculate their initial fluid rate based on percent burn.
Yes.
So tell me about when someone comes in, how you calculate the first fluid rate.
Of course. So it's important to remember also that this is for major burns. So major burns being defined as 20 to 25% total body surface area. So somebody who comes in with a 10% burn is not going to need a major resuscitation. But when we see somebody with a large burn, we calculate the surface area based on the so-called rule of nines. This is primarily for adults. The children are a slightly different beast because their proportions are different. But for an adult, of course, each arm is 9% of the total body surface area. Each leg is 18%. The anterior trunk is 18%. The back is 18%, and the head is 9%. So that roughly gives you a way to estimate the patient's total body surface area burn. And then for some patients, if it's patchy, we can use the Palmer method. So the patient's palm is roughly 1% of his total body surface area.
Okay.
So based on that, we would say, a 70-kilogram man with a 20% burn would get 70 times 20 times 2, and I'm afraid I can't do that math right this second, but that would be the total estimated resuscitation fluid for 24 hours. And as with the Parkland formula, half of that is given over the first 8 hours from time of injury, and the second half is given over the next 16 hours.
Okay. And during my training, we were using crystalloid for that resuscitation. Is there a place for colloids in blood now?
I think that's still very center dependent. So I think most people do not initiate resuscitation with colloid. Most of us will start with crystalloid for the first 8 to 12 hours. The theory being that there's a great deal of capillary leak in the first 8 to 12 hours. So any colloid you give a patient, either in the form of albumin or FFP, well, particularly albumin, I think that's the primary colloid that gets used, would probably just leak out of the capillaries and not be usable to the patient. But then after 8 to 12 hours, the idea is the capillary leak abates, and administration of colloid would actually be effective at that time. So I think most of us would start with crystalloid, and then this is the other change with the new formula, is that instead of, when we were in training, it was always just give them fluid and then give them a liter at a time. Increase, if they're hypotensive or not making urine, just throw another liter at them. And with the new formula, the recommendation is monitor the urine output on an hourly basis and go up or down on the fluid rate by 30% if that's as much as is needed.
Gotcha. Okay. And so tell me about monitoring urine output, invasive monitoring, non-invasive monitoring. Can you center yourself in the screen a little bit there?
Oh, sorry. There we are. Fluid monitoring or resuscitation monitoring, basically, I think the mainstay still is urine output. So we're still looking for a half a cc per kilogram per hour of urine output, ideally. I think we all accept that in the first several hours of the resuscitation, the patient may become oliguric. And sometimes, I think this is the other change, is just sort of sitting tight and waiting for that to abate. So obviously we don't want the patient to be hypotensive, but if the patient's normotensive and not making urine, maybe the thing to do is to increase the fluid rate rather than sort of saying in a reflexive way, just give them a ton of fluid. And this is quite different from what I think most of us learned in our training. If we trained in the last 10, 15 years, this has changed. So this is so we don't really give a lot of crystalloid, and the idea being that I shouldn't say that, we don't give an excessive amount of crystalloid. The idea is to give the right amount of crystalloid. It's a very much a Goldilocks and the Three Bears kind of thing, not too much, not too little, just right. And the issue has been that a lot of us were veering towards giving too much fluid, and so we were seeing problems such as ARDS or abdominal compartment syndrome. So we've really tried to back off of that and give sort of a more judicious resuscitation.
Okay. Is there a role for pressors early in resuscitation?
Probably not early, probably not in the first 8 to 12 hours, unless if by either invasive monitoring or ultrasound monitoring of the great vessels. You can see if the vessels are full, if the patient's adequately resuscitated. If the patient looks adequately resuscitated and is hypotensive, then I think there is a role for pressors. But of course, that risks compromising the already injured skin. So I think that's something that has to be made on. That's a decision that has to be made on a very individualized basis.
Mm-hmm. Well, let's say someone's a little later in the resuscitation, like a couple of days, and you're having trouble assessing the volume status. What techniques do you use in your ICU for assessing volume status?
We will use. We don't use Swan-Ganz catheters anymore. We would either use CVP monitoring, just as a rough guide, or arterial lines to have a good idea of blood pressure. Some kind of indwelling catheter will tell us better than a cuff, especially in burn patients. Sometimes you don't get a proper blood pressure reading through all the dressings. If it's if you've got a cuff on an injured skin, you just might not get the correct reading. And occasionally using, as I said, putting an ultrasound probe on the neck and seeing if the IJ is fully distended. That would be another way to tell.
Good. All right. Last words on how management of fluids early in burn patients has changed.
I would say just half of Parkland formula. Start with half of Parkland formula and go up or down as you need, and that'll prevent us from getting too much resuscitation on the patient and causing downstream effects.
Great. Thanks, Dr. Savetamal.
Thank you very much.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.